Welcome.
I'm tired.
Late in the afternoon, going into the second day or so. My name is Steve Ytterberg. I'm going to introduce myself earlier today. I'm a rheumatologist at Myositis. And I was asked to talk about heart disease. So, I couldn't get the computer to connect up here, so it's down here. So I'll walk back and forth so I don't have to stand in front of people. I do some consulting work with some companies, some fellows, and a statistician did some work that I'm going to show you. So, I'm thinking of heart things and myositis. I kind of put it into two different categories. One is thinking about what it is that the myositis itself does to the heart, or can do to the heart. And the second is, what are the long-term consequences of the disease and of the treatment? So sort of breaking it down to thinking the first part, so I think there's some discussion earlier today that myositis means muscle inflammation. And that's essentially what it is. Heart is a muscle, and sometimes the heart muscle can be inflamed. And the other issue is that with the inflammation that goes with this autoimmune disease, it's not limited to muscle, but you see inflammation in other areas as well. There was discussion during the panel today by several people about lung inflammation. So there can be inflammation in the lung as well as in the muscle. There can be inflammation related to the heart in the pericardium, the lining that goes around the heart. So we'll see sometimes inflammation of the heart muscle itself, inflammation of the lining around the heart, or pericarditis. And sometimes the inflammation can cause trouble in the structures that have to do with conduction of the electrical signal. Okay, so again, thinking that because of the active inflammation that goes with the disease, there can be direct trouble to the heart. And that can do things such as listed up above. So these were data that are from a review article written by Dr. Lundberg from the Karolinska Institute, who had been on our advisory board, and noted that it's infrequent for heart problems to actually be recognized. And she estimated from studies that have been published that congestive heart failure, basically poor pumping of the heart with backup of fluid, occurs in somewhere between 3 and 45% of patients with myositis. So this is in general. And then this is left ventricular diastolic dysfunction. I'm going to show you some diagrams here in a minute. But the idea that the left ventricle, which is the main pumping part to get blood out to the rest of the body, just doesn't relax well enough to get filled. So there are problems. They're said to be relatively infrequent. And like I said, we'll talk some about some of the things that come with the actual inflammation, but it's also then what are the consequences of having an inflammatory disease or being treated with prednisone that leads to trouble. So this is the anatomy class, okay? I stole these from the web last night. I don't know whose they are, unattributed. Looked like it would work. So the idea here is to think that blood comes in from the body in the vena cava, superior and inferior vena cava, and comes into the heart, into the right side, the right upper part of the heart, the atrium, goes down into the right ventricle, out into the lungs, and then after getting oxygenated, comes back into the left atrium, down to the left ventricle, and then out through the aortic valve and the aorta to the rest of the body. So this whole function depends on the muscle contracting efficiently and being able to relax sufficiently that it can fill to then pump out the next stroke of blood. So it's that, as I had shown in that previous slide, the idea of congestive heart failure is that it's not pumping effectively. The left ventricular diastolic dysfunction is that this can't relax enough to get filled for the next pump of blood. Okay. So that's sort of the pump function. But then, somebody else's website, is to think what makes it electrical signal to make the muscle go. And so the initial signal comes from the upper part of the heart, comes down, and then threads here to the other side, comes then down. So it's sequential. It contracts the top part first, the bottom part second. You get blood going down, up and out. So this was in the last slide, thinking of conduction abnormalities, that there's inflammation or scarring from previous inflammation. It might interfere with how the heart's getting the electrical signal. We can see things like atrial fibrillation and other arrhythmias, basically, that can occur with myositis. And then, sort of the last piece to it is that you've got the pumping function, you've got the electrical signal, but then for it to work, the heart needs blood supply. So, yes, it's full of blood, but the blood to supply the heart muscle to contract comes from the coronary arteries. Of course, these are the ones you always hear about, that if they're blocked, cause heart attack, the myocardial infarction. So it's this whole thing, the whole functioning and pumping mechanism depends on the heart having adequate blood supply. And a lot of what we're going to talk about later has to do with issues related to coronary artery disease or blood flow to the heart. Okay, so there are a number of ways, and just think of heart and myositis, is to break it down and say, what part of this whole functioning mechanism is being affected? And is this something that's coming directly related to the myositis, or is this something that's a later consequence of having had disease? And I'll take questions anytime. We've got a microphone that will come quickly. So, the effects of myositis on the heart, thinking that cardiovascular disease is often subclinical, meaning that it's not evident, but things can be happening. Those coronary arteries can be being plugged up without any symptoms. And cardiovascular disease is among the leading causes of death in patients with inflammatory myositis, but that's no different than the rest of the population. It's listed as the cause of death in anywhere between 15 and 60% of patients. I'll show you some of the actual data here in a second. The other thing that's known is that patients with inflammatory disease in general have an increased risk of heart disease. So it's been well shown in patients with rheumatoid arthritis and systemic lupus that those patients have heart disease at a younger age than average. It's more common than average. So in a disease like lupus, people are becoming aware that you see a young woman who's had lupus for 10 or 15 years who has chest pain. It's probably not pleurisy from the lupus, but you have to think that this may be heart trouble. So we know that in other diseases where there's inflammation that's going on, it sort of accelerates the risk of heart disease. So here is a slide I made from a number of published studies that range in year from 1982 up to 2006. And the causes of death in patients with myositis. So these are in different countries, different continents. So there are a lot of different factors that go in here. And you see a couple things. One is there's an awful lot of variability. So red is the cardiovascular disease. And red's the dominant color on here as an individual color, followed by cancer in purple, kidney disease, respiratory problems, infection. There aren't many that show infection, GI accidents and others. So what you see is that people list cardiovascular disease as cause of death in anywhere from 8% to 50%. So some is sort of how the data is collected. For a lot of these, it comes from death certificates, and it's hard to know if somebody had heart trouble, they were in the hospital, developed pneumonia, and died. What gets listed? Is it pneumonia or heart disease? So there is some trouble with data, but these, the idea here was to give the impression that what you see as the cause of death is heart disease. Again, this is much like the general public. I'm not sure where this one came from, with mainly cancer and no heart disease. So there are a number of ways to get data about this. One of the common ways that people do it is to look at what's known as administrative databases. So this is going to the government, going to the insurance companies, people who have lots of data. You can go and look at it. You can actually get data from the Social Security Administration about cost of death. Not for maybe actually for an individual, but they aggregate all these data and you can go and pull these. So this was from the Quebec province database, and they only looked at polymyositis and dermatomyositis. And how do you make the diagnosis? Well, they decided they'd say a patient had polymyositis if there were 2 billing charges for that diagnosis. So we don't know if the diagnosis was right or not, but so then they were able to take patients who've been seen as early as 1994 and follow them until they had a cardiac event, they died, or the study ended in 2003. And they wanted to know about drugs that the patients had taken, though this was all coming from prescription databases. Okay, so it's one way to do research, to use these big sources of data. And they compared to, actually they didn't compare to a control population, but this gives the risk of acute heart attack, acute myocardial infarction. Red is the women, green is the men. Here's age under 65, age 65 or older. So this is events per 1,000 person year. So you can move a decimal basically and say what percent of people have heart attacks. So for men over 65, it's 2.5%, 2.5%, women 1.4%, etc. The other is to look at kind of what gets included as acute vascular disease, is stroke as well. So that often gets lumped with sort of the idea of cardiovascular disease, not the heart directly, but it is cardiovascular disease. And so stroke was another thing that they looked at to get an estimate. This was a more recent study published in 2013. So this group from Stanford, this includes Dr. Fiorentino, who was also on this advisory board up until a year or two ago. So they used a U.S. sample. So the U.S. government collects data from hospitals. And this national inpatient sample includes about 20% of the United States hospitals. And so between 93 and 2007, there were about 7 million hospitalizations per year in this sample. It says 35 million in the whole U.S. And what is included in this database are diagnoses. So every time something's done in the hospital, a code is used for billing purposes, and this is collected. And so for every hospitalization, there has to be a single primary diagnosis, and then up to 14 secondary things can be included. So if somebody with myositis is admitted to the hospital and has a heart attack, that would probably be listed as the heart attack as the primary, but myositis would be one of the secondary diagnoses of diabetes or hypertension. So they can go through and search this database. They've limited the search to patients who are adults. So these are dermatologists. So this actually looked only at dermatomyositis. So they used the billing code for dermatomyositis and then looked for codes that had to do with cardiovascular disease or cardiovascular procedures like bypass surgery or angioplasty or stent placement. And they, from this database, picked 10 cases. So this isn't that they know who anybody is. There are no names attached, so don't worry about that. But they go through and find 10 patients of the same sex and age who were admitted at the same time and did not have dermatomyositis. So this is what's called a case control study to be able to compare the patients you're interested in with another group. And this is what they found. So over these, I think it was 15 years. It was from 93 to 2007. It was 15 years. So over those 15 years, there were 10,000 hospitalizations for patients with dermatomyositis. They had 76,000 controls. I said 10 to 1, but it's not 10 to 1. Mean age is the same. That's good because that's one of the things they matched for. Gender is the same. They matched for that, so that's good. The mean length of stay in the hospital, the myositis patients were in the hospital an average of 8 days, the other patients 5 days. The mean total charges, 28,000 for the dermatomyositis patients, 33 for the others, because you don't know what they had. Were they in for cancer, chemotherapy, radiation? And this comorbidity index is something that people who do this kind of research use. It helps adjust for how sick the patients are. So comorbidity means what other illness is there. So in addition to the myositis, what other things? Do they have diabetes? Do they have hypertension? Do they have thyroid disease? Whatever. And what was most striking was the death rate, that 5.5% of the patients with dermatomyositis admitted to the hospital with heart disease, not all, but these patients all had heart disease also, died in the hospital. 2.5% of those with heart disease without myositis did. They all had a heart code also. So that shows up here. So with the heart characteristics, 20% of myositis patients had something doing with the heart when they're in the hospital, 21% of the controls. Acute MI, 4%, 6%. Angina, about the same. Congestive heart failure, maybe a little more in dermato patients. More bypass surgery. I'm not sure why these numbers were zero, why there were no cardiac catheterizations. I've looked at the paper a couple of times. So what they can do is to basically generate the odds ratio. Looking at what are the risk factors, and then you ask what might be modified. So these are the odds of a patient dying during the hospital, comparing patients with dermatomyositis and heart disease and those with dermatomyositis without heart disease. So patients with dermatomyositis might have been admitted for pneumonia or cellulitis or maybe even cancer treatment, but it wasn't heart. But if the patient was in the hospital for a heart condition, they had twice the risk of dying of patients with dermatomyositis who didn't have a heart condition. If they had an MI, 1.5 times. Angina didn't seem to matter. Congestive heart failure did. So, but then you say, well, okay, why do patients with dermatomyositis or other myositis go in the hospital? Well, it might be heart condition, but then for other things, it seems most of the other things might not have the risk of seriousness or fatality that the heart stuff does. So that's maybe intuitive. But this then compares the odds for in-hospital of patients with dermatomyositis with heart disease and those control patients with heart disease. And again, it looks like the chances of having a bad outcome in the hospital are about twice as high for the dermatomyositis patient as it is for the controls. And again, I think, say, well, yeah, there are a lot of other things going on. Patients with myositis are probably getting prednisone, they're probably getting an immune suppressant drug. So there are other things, but it goes to show that there is definable risk related to the disease and its treatment. So these investigators did something called a meta-analysis. So this is a statistical technique. How's the story go? Liars and statisticians. I don't know. But this is a statistical technique where investigators can go to publish. So they didn't do their own research per se. They didn't look at their own patients, but they went to the medical literature and found these 4 articles, including these 2 that I showed you before, the Linus and Singa, and sort of lump them all together and say if we adjust for how many patients, how sick, or this and that. But you make assumptions because you don't know that the conditions were the same in the 2 groups. But essentially, they came to about the same number. This is called a forest plot, and it shows sort of the risk for the individual studies and then the combined. How broad this is an estimate of the reliability of the measures. It's a statistical measure of how confident they are. And the shorter that is, the more confident, the longer it means that they're less sure about it. But the fact that it doesn't touch 1 means that it is statistically significant. So it's about a 2-fold risk, is what they said. The same group also looked at stroke risk, and this one study that I showed you previously looked at stroke also, and overall the risk of stroke in patients with myositis was about 1.5, 1.6 times that of control populations. So let me just show you this. Actually, I did this talk maybe 3 years ago for this group, and so I found the slides from that. And I looked at this, what the heck did I have to say? JDM. But as I looked at it and reread the paper, this was a very interesting study. So these were patients who had juvenile dermatomyositis, so it came on before age 18. These patients were diagnosed initially between 1970 and 2006. It was a study done in Norway. They looked at controls, but what they did was they contacted the patients and brought them back in to examine them between 2005 and 2009. So of these patients, they had 60% were female, as you'd expect for this disease. The age at onset was just under 8 years. Age at diagnosis was just under 9 years. They had been followed for almost 17 years by the time they re-examined them in 2005 to 2009. And at follow-up, the average age was 21, with the range going from 6 to 55. So basically, they've got patients who had disease and then re-examined them a number of years later. And this is the result. So these numbers come from echocardiograms. I should have started this. I'm not a cardiologist. I'm a simple rheumatologist, okay? And they can calculate what's called this E prime thing from different things they measure on the echo, and it has something to do with how the heart pumps. As much as I know. But higher is worse. And basically what they showed was when they examined these patients 17 years later, that how sick the patients were at the beginning. Actually, this was a year after diagnosis. How this DAS score is a disease activity score that we calculate thinking of what's going on in the muscle and the skin in total. And basically, the higher the DAS score means that the doctor thought these patients had more active disease. And when they were examined 17 years later, those with more active disease had worse heart pumping function. Arguing that treatment's good, right? And that maybe if we can control things better initially, longer-term function and outcome will be better. So I didn't want to talk too long, but let me show you to leave time for questions. Although I've learned if you talk long, you don't leave time for questions, you don't embarrass yourself by not knowing things. Yeah. There's the microphone.
My name is Pete Rovich. I'm an IBM, and I'm just wondering if any of your studies included people with IBM.
Yes, some of these have IBM patients. The majority have been polymyositis dramatic. I will admit that. I think there's reason to think that much of what's there, especially what I'm going to show you next, applies across the board. And there there's less published evidence, I'm not sure that it's not there. If that makes sense. I don't hear the pericarditis around the heart and pleurisy. Those are more symptoms that sort of overlap with other connective tissue diseases that I think we see more in dermatitis and polymyositis. And I have to admit, everybody says I'm an IBMer. I pause because in Rochester, Minnesota, the second largest employer is the International Business Machine. And the guy who lives across the street from me is an IBMer. Was there another question? So, risk, and there are a couple of people who are looking at this. This was something that one of our fellows did back a few years. So she looked at all of the patients seen in our division of rheumatology. Again, she limited it to polymyositis and dermatomyositis. They had to be adults. They could have pure disease or overlap disease. And she excluded, in retrospect, I'm not sure why we excluded the IBM patients, in truth, and excluded patients with malignancy. But we had seen 156 patients in our division over the course of that year. A couple she couldn't calculate, were missing data to calculate risk, and she excluded patients over the age of 80 because we compared it to published data, which didn't include patients over 80. We only had patients up to 79, so she excluded those. And for thinking of risk, used this published set of data. Off the chart. So 156 patients, average age of 55, 66 women. That doesn't add up. Oh, those are percents. Oh, those are numbers. That doesn't make 156. 2/3 women, about half dermatomyositis. They had disease for a median of 5 years. And one of the questions was, does it matter whether the disease is active or it's been in remission? So 30% were active, 70% had stable disease. No, so the overlap usually is used to mean those with other autoimmune diseases like lupus or scleroderma, so one of those. And a fair number of these patients do have interstitial lung disease, but that she didn't calculate out separately. So for the cardiologist doing studies and to define who should be treated with statins and other drugs, they assign patients to be high risk, moderate risk, or low risk. And the calculation comes from this. So it's to assess high risk cardiac heart disease determinants. So if you've had heart disease, you're high risk. If you've had symptomatic carotid artery disease, it gets back to that idea of stroke sort of being an extension of heart disease. So if you've had symptomatic carotid disease, it's high risk. If you've had peripheral artery disease, high risk. If you've had an abdominal aneurysm, high risk. And the presence of diabetes puts these patients into the high risk category when it comes to thinking of treating high cholesterol. With none of those, then it's to assess the HDL, to know whether there's hypertension, history of cigarette smoking, family history of premature coronary disease, and age is a risk factor. So age for men over 45, high risk. That gets you a risk point. So if you've got 0 or 1 of these, it's low risk. If you've got more than 2, then it's to calculate from another calculator the 10-year risk of having a heart attack or other things. That's less than 20, that's all that matters. It's greater than 20. So this is just basically how they define who's at risk and who should be treated for cholesterol medications. So we looked at our patients with myositis, and basically this is where they were. 68 were low risk, and the 156, if they followed the way the rest of the population goes, we'd have expected 107 of them to be low risk. We found 43 to be moderate risk, we would have expected about 34. We found 37 to be high risk, we would have expected only 6. to be high risk. And that carries for men and women, and I'll show you that in a graph here. I'm a visual person, I see it this way better. So this is the data just for the men. So this is for the published data for the U.S. This is for our cohort. So this is our, by decades, 20 to 29-year-olds. All of ours were low risk. Once you get to the 30 to 39-year-olds, we would have expected this many moderate. That's how many moderate we had. When you keep moving up, by the time you get to the 60 to 69 cohort, actually the low risk we had more, but the high risk was way up. And in the patients up to 70 to 79, we had many more high risk than would have been expected. And this is why we quit at age 80, because there aren't published data for people beyond 80. So basically, we had much more risk among our patients with myositis than would have been expected in the normal population. That was true for men and for women. And what was really striking for me was to see this in this 40 to 49-year-old group, where the expectation is really low for women. And actually what we found was, 22% of our women were high risk for heart disease, or high risk in determining whether a statin was inappropriate, basically. So of those risk factors that I said, how many of them did our patients have? Again, we had 68 low risk, 46 moderate risk, and 40 high risk. Age actually drifted down here. This is men and women. So hypertension, see that 78%, 73% of the higher risk people had hypertension. Hyperlipidemia gives up 52% and 70%. Tobacco use, family history of heart disease. So the BMI is a measure of weight and the presence of chronic kidney disease. So there was a good bit of hypertension, a good bit of hyperlipidemia. And these contributed a good bit, as well as male gender, to being in the high-risk category. And this basically shows that it doesn't really matter whether it was DM, or overlap. Patients had somewhere between 4 and 6.5 years. The prednisone doses were all pretty low and stable disease. The percents were essentially similar. So these were the recommendations for statin treatment when we did this study. If you heard on the news last year, there was all this hullabaloo that statin recommendations were changed. Now virtually anybody ought to be on one. So for high-risk patients, the goal of treatment is to get the LDL, the bad cholesterol, less than 100, but to think of treating if it's over 130. For moderate risk, so where to treat, 130, 160, 190, depends on whether you're low risk, high risk, or medium risk. And this one I just downloaded last night. You can't read it at all. That was sort of the intent, was to give you the idea that the new guidelines are a lot more complex. But the bottom line is take a statin. We didn't do such a good job of patients. And it actually gets to sort of an issue of care of patients with myositis, of who's in charge and who's running the show. And I usually take responsibility for the prednisone, for the methotrexate, for the IVIG, for all of those kind of drugs, but leave the hypertension treatment to the primary doctor. And I've wondered if we should be learning how to take care of hypertension. So of our patients who had hypertension, how many of them had a systolic blood pressure below 130? 0 out of 4 in this group. At least half of the moderate group had their blood pressure was at target. And in the high-risk group, only about a third or so had blood pressure that was appropriately controlled. Not many patients were on aspirin. And then we said, Actually, 19 of the 40 high-risk patients would have met the guidelines that could be treated with the statin. Here and here, we did have some patients on the statin, which gets me toward the end of this, and I'm going to do some audience participation in a minute. And that gets to do, we say that there's risk of heart disease in people who have myositis, and one of the things that we want to do is to get cholesterol down. Is it okay to give cholesterol-lowering medications to patients with myositis? And I'm going to ask you all what you've been told by your doctors. This was a study published by Christina Charles Schumann, also on our board, a few years ago. And what she did was to publish an online survey of the IMAX members. So that's the International Myositis Assessment and Psychs group, and got 63 responses from across 23 countries, and 76% of these patients, or these doctors, said that they do use lipid-lowering drugs in the patients with myositis. Statins were the most commonly used drug, and among 300 treated with the statins, these physicians reported 36 cases of worsening myositis, and some of them noted that worsening improved after going off the statin. It's not rigorous research, but it's some idea of what people are doing. So here's my last slide. The bottom line, I think, is doing things to control disease activity, because there's some evidence that if you leave the inflammation going, it may have bad implications. That if we want to reduce the risk, and this is something that's being studied in the rheumatoid arthritis and lupus world also, that it's looking like there are other risk factors over and above the cholesterol, the hypertension, but we should at least treat the modifiable risk factors. But then when it comes to cholesterol being one of those risk factors, the question is what to do about statins, since there's no firm evidence, there are no guidelines about what to do. So, I'll put the lights off, I guess, and take the question first.
Thanks, Dr. Ytterberg, for all the information you have mentioned in the presentation. My father has an IBM, and prior his diagnosis, he had some emergency case. I think he fell down. We took him to the hospital, to the emergency room. They made some blood analysis, and they said you have heart problem. And when I asked the doctor why, he said he has very high troponin enzyme, heart enzyme. I would like to ask you, this common in IBM patient to have troponin enzyme elevated in the bloodstream?
Yeah. Sure. So troponin is another one of the muscle-related enzymes. And so usually when patients talk to me about myositis, they tell me about what's happening to the enzymes. And so CK, or creatine kinase, is one of the main ones that we look at. We look at LDH, aldolase, AST, and ALT. But troponin is another muscle-related enzyme. And there is some controversy about it. It was proposed, so way back when, CK was thought to come from heart. It was known to come from muscle too, but it was used to help diagnose heart attacks if the numbers were high. Then, knowing that it could come from muscle or heart, they identified subtypes of CK. So there's the BB type, is in the blue segment, the MB and the MM type of CK. And the MB was said to be specific for heart. And I remember probably 30 years ago, there were publications reporting heart disease in patients with myositis because they were finding elevated CK-MB type in the blood. Well, it turns out that yes, MB is associated with heart muscle, but it's also made in regenerating skeletal muscle. And if those regenerating fibers are done in by the myositis, you get high MB also. So that sort of blew that out of the water, and all these studies that said, oh, there's this high incidence of heart disease in polymyositis. because of the high CKMB was false. It was just that we didn't know enough. Okay. So people keep discovering other things, and troponin is found as another muscle-related enzyme. And there are a couple of subtypes of troponin. And I forgot, there's troponin I and troponin S. One of them is said to be specific for heart. The other one was felt to be specific for heart. Then they found it can come from muscle also. So I think it's not totally clear. But one is supposedly more specific, but I'm not sure that it is routinely measured. I think the other one is the cheaper one to do. So it's hard to know. So other questions? This one back there. And I'm going to ask people about the cholesterol. Who takes cholesterol medicine?
I know that you can't give specific advice for individual people or whatever, but I'm supposed to have an aortic valve replacement and maybe an ascending aortic aneurysm repaired in a few years whenever it gets bad. Do you think with being on CellCept and Plaquenil, in general, if you have patients that are on immune suppression drugs, my myositis is very stable now. I'm actually asymptomatic since I've been on the medications. But do you think it would be good to wean off those if I have time to do that, or wean down on them, and or be on some kind of isolation when I'm in the hospital to kind of be on safe?
So it's always a question of why the aneurysm is there and why the valve is there. Most of the time. Pardon?
Is a bicuspid aortic.
Okay, so bicuspid valve. So a normal aortic valve has 3 cusps to it that open and close as the blood's going through. I forgot what the percentage is, but a not insignificant percent of patients have aortic valves that only have 2 cusps. And they don't function appropriately, and over time, my understanding, not a cardiologist, they wear out sooner than the normal ones. And as that happens, the aorta, where it's attached, gets damaged also. And there are some things that they measure, which I don't know, having to do with how easily blood gets through, how much obstruction there is one thing dealing with the valve, but they also measure the size of the aorta itself. And basically, they know at some point it's time to do the replacement, because there's risk of doing the surgery, there's risk of having the aorta rupture, but if it's not very big, the risk of rupture is less than the risk of the surgery. So it's very clear. It's either 5 centimeters or 6 centimeters. Whenever I have patients, I look it up just so I know that. But it's pretty clear that the risk goes up steeply once you hit that 5 or 6 number. So it's usually done electively after following for a period of time. Okay, so that's that. So it is. What I see with our surgeons is that they worry about immunosuppressive drugs and steroids and would like people to be off of them. And we say, well, sometimes we can, sometimes we can't. So I didn't give specific advice. In general, I think that if, say, gosh, things are quiet now, why don't we try to taper off? Because there are some people who have, with not the IBM, but the polymyositis rheumatica, have sort of a single flare, and you don't know it's going to be a single flare and not flare up until you try to taper off the medicine. So as was discussed this morning, a couple of years, I usually treat with steroids, treat with something like the CellCept. Things get better, taper off the prednisone, keep the CellCept for a while. If things are still doing okay, say, well, should we try to go off? Because it's the only way you know if it's going to flare or not. But otherwise, wanting to minimize. But the concern is infection, mostly, and wound healing is what they always talk about. Well, yeah, I want to ask about cholesterol. I should answer your questions, I know.
I had a flare-up in the spring, and when the doctor was trying to lower my prednisone, he also lowered the methotrexate. So I had a lot of pain in my chest, and I kept telling him that, and he's like, oh, go to a cardiologist. And I said, well, I think I probably need more prednisone now, more medication. He's like, no, go to a cardiologist. I went to a cardiologist, got an EKG, everything was fine. And then he said, again, I continued about the pain, and he said, well, then go to the ER and get it taken care of. So he didn't do, so again, I went went to the ER, and again, they did another EKG, they did a stress test, they did all kinds of tests regarding my heart, and then they gave me a big bulk of prednisone and some other medicine that they use for the heart, I guess, to control it better, and eventually the heart thing kind of stopped, but it was like over a month. So like now I'm thinking, with the heart being a muscle, did I ever do any damage to the heart during that time?
So the question of chest pain is one that's not infrequent, and the question is, where's the pain coming from?
Right, exactly.
Is it heart? Is it something related to the lung? Is it musculoskeletal? Are sort of the main things there. Heart and aorta hooked together. So it's, thinking through how I would approach it is to say, what's the character of the pain? Is this sharp? Is it dull? Is it achy? Is it related to exertion or not? Is it change of motion?
If I'm just standing, it's just, especially like if I'm...
I wasn't going to diagnose you. I was just going through the thing. is to say that this could, so things, you worry about bad things first, right? So is this a heart attack?
Right.
The other is this a pulmonary embolism? Is it blood clot in the lung? So those are bad things. So usually in the emergency room, they want to do the electrocardiogram, they measure these enzymes of various types in the blood, and then it's whether to do a CT angiogram to look for something in the lung, blood clot in the lung. But then other things, there can be inflammation related to the autoimmune disease, to think that there's pericarditis, inflammation around the heart. There's pleuritis, inflammation of the pleural lining around the lung. And those are sort of the big ones. Then you start thinking of other things. Is this really just reflux? I shouldn't say just reflux. Is this heartburn, bad reflux that's causing chest pain? So there's sort of a number of things to think about. And from the heart side, then it's to say, okay, we can do an electrocardiogram, we can see an echocardiogram, and at some point is it something that looks at the coronary arteries, are they being fed well enough?
Well, I was just wondering, because of that, and I had that constant pain, would there be any damage to that heart? Because it was that constant pain that I had that didn't go away for like a month.
So actually hearing that, you're going to say, gosh, this probably wasn't angina, heart attack kind of pain. So I'd say probably not. Not missing that one.
How do you diagnose the myocarditis? What tests do you do?
Yep, very good question. So I thought about putting in some of those things. So the tests to think of looking at how the heart is working and how it might be involved with myositis. We do an electrocardiogram, looking for those conduction disturbances, say little squiggles that are looking at normals, where we see those. Also on the conduction side, some people might need a Holter monitor to look at what the heart rhythm is over a longer period of time. But for the myocarditis, there are really two tests. Again, not a cardiologist, but my understanding, it's doing an echocardiogram. So with the echo, you can see the pumping function, you can see the valves to see if they are bicuspid or normal looking. And a heart that has myocarditis or inflammation in it can have some areas that don't contract normally. So that's one of the things that they look at the echocardiogram. It's called wall motion abnormalities. So in patients who've had a heart attack, come back to this pretty picture. What this is trying to show is blockage in an artery here, and then it's not nice red blood, but this area is not getting blood supply. This muscle dies. And when they do the echocardiogram, they can see areas that don't contract normally. Okay? But if there's inflammation, not that it's bad like this, but if there's inflammation in that area, they can see areas that don't contract normally. But the other more sensitive tests that they're doing lately is do MRIs. And there are some specific findings that they see that suggest an area of inflammation in the heart. Again, it's not going to contract normally, and they can see areas of inflammation.
thought I would address your question about cholesterol medication.
Yeah.
My husband has IBM, and he's been going to the Mayo Clinic in Rochester for the last 5 years. And his neurologist said absolutely no statin, and she has him on phenylthyroid.
Okay, so that's a good segue. Should I ask Susan right now? Dr. Maloney. That's okay. I know wrong. So, I assume it's a mix of patients and caregivers. Who has high cholesterol? No, it's a very personal thing to ask. And of patients, how many have high cholesterol? Yeah. No, I was thinking of anybody who has high cholesterol. That's why I raised my hand. And patients, we've got a number, they have high cholesterol. And treated with medicines for it? Tried? No. Yes? No?
My husband was on several statins for about 12 years. And then he started having the symptoms that in hindsight was one of the symptoms of the myositis, the deep skin itch on the long muscle and the lower leg. And he had that for 4 years, and his family practice person was treating him with dermatologic preparations. And it only took one visit, after then we started having a muscle failure. For someone who was experienced with it, to know that that was one of the cardinal signs. But he'd been having those symptoms for 4 years.
So let me say a few things. First, I always tell patients I have the utmost respect for the primary care doctors. Because I have the utmost respect for primary care doctors because they're seeing patients with all kinds of symptoms. I mean, they come in with complaints of meal and so so we see patients who have myositis with interstitial lung disease, and I can't tell you how many come and say, well, this stupid guy was giving me antibiotics for pneumonia and didn't know that this was, well, that's exactly the right thing to do. If you see somebody who has shortness of breath and an abnormality on the chest x-ray, this isn't myositis with interstitial lung disease, this is pneumonia until you've tried to treat it and it's not gotten better. So it's that sort of thing to say if somebody's on a statin, the first thing the docs at home should think of shouldn't be IBM. Could be, but so that's where I start to say that, I really think that, they've got so much to try to juggle and take care of that somebody with muscle aches, muscle cramps, can be so many other things. But the issue with the statin use has made evaluation of our patients much more difficult because so many people take them that you see we get sent somebody who has muscle symptoms, whether it's muscle aches, muscle weakness, elevated CK, and half of them are taking a statin or have been on a statin. Usually the primary doctor stopped it some period of time before, and they didn't get better, and so they referred them for evaluation. Then it's a question of how long you have to be off it to know that you've excluded that as a possibility, because it's not a quickly on-off kind of thing. And we haven't gotten into talking about the various kinds of statin muscle problems that sort of the common is just having a high CK or some muscle aches that go away when you go off the drug. And then there's the stuff that talked about Dr. Mann describing a particular antibody that causes ongoing muscle damage even when you go off the drug. But there are also described patients who had been on a statin and were found to have a muscular dystrophy, a hereditary inherited disease. The statin didn't cause it. But what we think is that here's somebody who had this disease all their life, but it wasn't bad enough to come to attention. It wasn't causing trouble. At least I had one farmer with a muscular dystrophy who could barely, but he accommodated. could do things on the farm, but he was lacking biceps. But he didn't think that was abnormal because he didn't think that all his life. So anyhow, I think that these cases where people were on a statin and they were found to have a muscular dystrophy is that the patients hadn't had any symptoms, have never been investigated. Suddenly they get muscle aches or cramps. The doctor doesn't see it's abnormal. They do an EMG, they do a biopsy, and they find this disease. So it gets to the question of whether statins cause IBM. I don't think so. I really don't. I think it's that the patient was getting symptoms and maybe it was slowly progressive as IBM does, and maybe the statin worsened things. But that gets to the question of whether it's safe to treat people with high cholesterol with a statin, which is where I was going with this eventually. And it's not clear. There isn't good evidence, and some people are dogmatic to say you should never take this. And I used to have that approach, but I've lightened up some, and it's because I think that you've got to end up balancing things. I worry about giving a statin to somebody who has a lot of inflammation in the muscle, sort of that acute onset, a lot going on in the muscle, with it being very active. But for patients who've been relatively stable, or the IBM patient that's been declining at a fairly predictable rate, then I say, well, what's the risk of the heart? And if somebody had a heart attack, they probably are better off being on a statin than worrying about potential trouble to the muscles or not. That's sort of my approach. And I think other doctors may weigh the evidence differently. You've got to think about individual patients. But we have some patients, and I've been meaning that this data that I showed is several years old now, and we've not gone back to look to see if those patients on the statin have done worse. My sense is they haven't, but we've not formally pulled that as a look.
My rheumatologist referred me to a nephrologist just to make sure everything was copacetic, and about a year ago, when they did my blood work, she said that my cholesterol had gone up quite a bit, and she wanted to put me on a statin. And my wife, who's a registered nurse, who always goes to these doctor's appointments with me, she's one of these folks who's pretty dogmatic against me putting me on statins, and she told the doctor, not only no, but hell no, and she said, we'll take care of it another way. So she put me on a diet and everything, and sure enough, my cholesterol went down. My question is, earlier you mentioned about coming off of prednisone. And when I was first diagnosed, I was diagnosed with polymyositis, and they put me on prednisone, and then subsequently, after another biopsy, changed it to IBM. And my doctor's been trying to wean me off of the prednisone, and every time I stop taking it, I get deathly ill. I mean, it's like I feel like a heroin addict coming off of heroin, and I can't eat. Last December, I lost 30 pounds. All I could eat for the whole month was beef broth. I couldn't hold anything down. And so they put me back on the prednisone just to keep me alive. And now he's trying to wean me off it again, and I'm afraid to stop because I don't want to get sick again.
So that's how quickly it came off when you went to stop.
We weaned it down so that I was taking, I started out at 20 and I dropped down 5 milligrams per month until I got down to about 5 milligrams, and then he wanted me to stop.
Yeah. So I'm not sure how to explain that sort of deathly ill and weight loss. Other than thinking that you were Addisonian, which means not making enough cortisol. There's a technical word for being low on steroids. And patients who don't make enough cortisol can just feel terrible and hear nausea and electrolyte changes. It's maybe it was slow enough, but the average person makes cortisol as the natural steroid when we treat with prednisone we stop making. So the amount of prednisone equivalent to the average cortisol production is about 7 prednisone. So I usually worry about people having symptoms somewhere in the 10 to 5 range. Personally, I don't like stopping people cold turkey from 5. I generally, first time I'm coming down, I do 10, 7.5, 5, 2.5, and off. And tell my patients that they may not tolerate it. That may be too big a drop, because when you go from 7.5 to 5, you drop the dose by 1/3. When you go from 5 to 2.5, you drop it by 50%. percent. And it's, I think, often the relative change as well as the absolute change. So, first time, I always have discussions with patients, we're going to try to go off, or we're going to do it, or if we decide we're going to go off, first time I try, I usually do dropping 2.5 milligrams every 2 to 4 weeks. And I'd say 2 to 4, telling them that sometimes you may get this withdrawal effect and feel crummy. If you feel crummy when you went from 7.5 to 5, and it lasted for a week, well, I feel good for another few days to a week before you do it to yourself again. Maybe stretching that out 3 or 4 weeks before but even some people can't do that. So then I retreat to where they've been, whether they're 7.5 or something, and then go down to 1 at a time. And then think how that you may have to be stretch out more than a couple of weeks. So I don't know if it was all just withdrawal. The other argument is that there was something inflammatory going on that's being treated.
Could it be possible that my body stopped making cortisol?
Yeah.
Because I've been on prednisone for so long?
And there's always the debate about whether people don't kick in and start making it again. The other thing that I see, so it's off on a different tangent. A few years ago I talked about prednisone, but if that's the question, I tell my patients that the goal is to get off prednisone, but we may not get off. So conceptually, I've got this paradigm that if it's an autoimmune disease, you treat with an immune suppressing drug because it's the immune disease that causes inflammation. And the inflammation causes the symptoms. The prednisone is working on the inflammation. These other drugs, not Trexate, are working here. And if we want to get all the way off prednisone, we've got to treat more aggressively here. So there's risk with these drugs, and at some point you say, is it worth trying to get to zero? So I had one guy who felt great. He had Myositis with interstitial lung disease, one antibody, and I'd been following him for decades. He felt great. He could do everything he wanted. The only time he knew he had an illness was that when he went deer hunting with his buddies. He had trouble keeping up with him in the woods. Otherwise, he was fine. And so I looked at him and said, gosh, you're taking 150 milligrams of Imuran, 6 milligrams of prednisone, your strength is normal, your enzymes are normal, no rash, why don't we try tapering? He looked at me and said, well, I'll be happy to try again, but if you remember the last 4 times, it hasn't worked. And so I looked back through the records, and at 6, he's great, at 5, he started to get symptoms, at 4, he was clearly worse. So we tried to push the Imuran up, and the platelets went down. We tried cell set earlier, and didn't tolerate it. We don't like to use Trexate always with interstitial lung disease. So I said, maybe 6 isn't so bad.
Yeah, gotcha.
So a few years later, he actually did get lower. But,
Thank you.
Anyhow, long story, a different subject. Not totally different. Prednisone may have something to do with atherosclerosis.
I was going to just tell you what my husband's with going on prednisone. Again, like the gentleman there, we first thought it was poly, and then determined it was IBM.
Common story.
But in that year, it was on prednisone for a good year. I think it was 60 milligrams. And the neurologist at Mayo, we took a year to wean him off of it, down to finally increments of 1 milligram a day. Right?
Yep.
For a month.
Or dropping a milligram every month. That's
Yep.
that's something that I commonly do also. If we have some people trying to get those, having trouble getting off, going 5 per month, 4 per month, 3 per month. And I've got some people who are so afraid that they break the ones in half and do half milligrams. But it's okay. You're just weighing the side effects, the risk of having things flare or having symptoms worsen versus the risk of the drug. And as I said, I often tell patients that the average production is about 7, so once you get down to those lower doses, the risk is less also. They're done already. Oh, fenofibrate is another drug. It also can cause muscle trouble. This is one of the problems. And in fact, there's good evidence that for patients with bad hyperlipidemia, high cholesterol, the cardiologists sometimes use the fenofibrate plus a statin, and the risk of muscle trouble goes up good deal when you combine the two.
Going back to the prednisone, do you feel it's better to do, if you're on 10 milligrams, to take one every other day or
Yeah, so
daily?
you need to take 20 every other or 10 daily or 10
You're taking 10,
Yeah.
like say 5 every day instead of 10 every other day.
I tend to be an everyday person. In truth, I think there is more art than science around the use of prednisone. And there aren't a lot of studies that say this is the best way to do it. I'm from where it was invented, discovered, which it was, where it was actually first put into use for treating rheumatoid arthritis. And they had dramatic effects with it, but also very quickly saw a lot of the side effects, which can include muscle atrophy, muscle wasting, and weakness. So it's trying to, anyhow, I tend to think that for our autoimmune diseases, daily prednisone works better than every other day. But for the same total dose of prednisone, the more you split it, the more effective there is, good and bad. So for people who are really sick with this, I'll sometimes do 20 milligrams 3 times a day, which is actually more effective than 60 milligrams once a day. But it's also kind of more side effect risk. It's just because of the half-life of the drug, it's more potent doing it that way. So the extension was people said, okay, when we're trying to taper it, let's go every other day, because then there will be less risk. But I think that that's too long a time without prednisone for these diseases.
Well, with the every other day, does the body manufacture
I don't think
No.
it doesn't really. I think it's the total dose that it's not a. For people who've been on it for a long time, the way I express it for my patients is to think it's like the factory shutting down during the summer, and it's that the machinery gets disassembled. So you can't just flip the switch and have it start making cortisol again. You've got to give time to have the brain sense that it needs to make it, get sort of things going in the adrenal glands again, and it's a slow process, not an instant on and off. Yes?
So if you're at 5 milligrams of prednisone,
Is your body producing the other two?
I always hate that question. Because it seems it should, right? And if it should, then you should be able to get all the way off. But we get people who get stuck at 4, 3, 5. And what I told you is true. Sharp audiences. It seems it should be that the body starts producing enough that you can get all the way off. But some people just, we can't. There are some older patients who we treat with prednisone and we try to get them off. They don't do well because they get achy and stiff. And for that, I think we're actually treating some of their osteoarthritis, some of the wear and tear kind of arthritis, that all the symptoms went away when they were on bigger doses of prednisone. And you start to take it down, and suddenly the knee pain and the hip pain comes back. And so I sometimes leave people on low doses of prednisone just to treat that. Thinking that the option, if they haven't done okay with acetaminophen and Tylenol, then 3 milligrams of prednisone might be safer than the ibuprofen, clofenac, anti-inflammatory drugs.
In the literature, I've seen where the immunosuppressants over time can make you more susceptible to bacterial type infection. Would that also include viral? And if so, things like cardiomyopathy, does it kind of make you more susceptible to things of that nature?
Yeah, it's sure nothing that I worry about or tell patients about. I mean, I discuss immunosuppressives having risk for another infection in general, and that is bacterial, viral, parasitic, other kinds of things. But cardiomyopathy from a viral cardiomyopathy is a pretty rare thing. So yes, technically it does, but I don't know that I've seen it.
damage?
The question was about Humira causing heart damage. Humira is one of the TNF blockers. I don't know yet. I don't know that I could. And there's concern about those drugs with infection. There's concern about cancer. They've been linked to some patients, to interstitial lung disease in some patients. And I don't know heart.
So that is one of the side effects the medicine advertises. So in my situation, I have been on Humira for about 2.5 years. And just recently I developed some chest discomfort and other heart issues. So I had a cardiac done, and it showed that my heart had reduced function by 40%. And that was since August of last year. I had a echocardiogram done, and my heart was functioning fine.
So the question was about the heart function, so that's not...
So what happened is the doctor upped the dosage of the Humira from every other week to every week.
Yeah.
And they took me off of all of my supplements.
Yeah.
And that's when I started to have problems. So nothing else changed other than the dosage of Humira and my supplements not.
Yeah, I don't know. So the question was about the heart function, so that 40% number comes from the echocardiogram, where they can estimate what percent of the heart, what percent of the blood is squeezed out with each contraction. But I don't know. I have to look that up. I don't know. It's a new one.
The rheumatologist is saying it's the disease itself.
Well, that's what
I've had the disease for like 9 years now.
Yep, but the argument is what I showed you, that over time, it seems that the risk goes up. And so I worry...
Can it go up in 6 months?
I think it can. But I worry more that it's something happening with the heart rather than the drug. So others? Where you guys at?
Me again. I was diagnosed with myositis in 2000, and about 3 years later, I developed a cardiomyopathy, and they couldn't figure out any other causes for it besides myositis. And then, so my question is now, they're looking at other types of treatments. Are there any medicines that I should avoid since I have a cardiomyopathy?
This is where I'd ask the cardiologist their opinion, and knowing what they do as far as drugs to facilitate the pumping of the blood. But I don't think offhand the particular ones of our drugs. So there's some cancer chemotherapy drugs that can interfere with heart function, cause scarring. As far as working it up, this might be the kind of place for looking at the MRI. See if okay. So can't have an MRI because of the pacemaker. So then it's probably looking at the echo is probably the best they have. I don't know if they have some nuclear medicine in these hours.
Do you have any experience with patients doing hormone treatments in relation to prostate cancer that keeps rising? IBM that keeps, against IBM, unless we have IBM, and they suggest that they do hormone treatments. Do you have any idea if this is effective or not effective, or does one work against the other? Do you have any report at all?
No, I don't know. I have to think about that and look at it in the literature. So the question is a hormone treatment an anti-testosterone drug? Because testosterone has some effect on muscle bulk, and I don't know offhand if that's been reported in literature or what to think about that. But I actually would want to know, I have no experience. So I'd look in the medical literature to see if there's anything published and talk with the urologist. But sometimes we get stuck to the point, it's sort of the same issue, heart disease and myositis, do you use a statin or not? That you get sort of conflicting situations, and what's the most important to treat? And how to balance those risks. Good question.
My husband had a heart attack about 2.5 years ago. Just got diagnosed with IBM a year ago. And his cholesterol is not high. His good cholesterol is very, very low, but his bad cholesterol isn't in a normal situation something you want statins for. But because he had the heart attack, they want him on statins. It did seem to have an adverse effect with the muscles. And our cardiologist is still pushing to go with the statins. What's your opinion?
That's difficult because cardiologists are like laser focused.
Well, that's basically what he said was, this is what we always do with all of our patients. And it's like, wait a minute, we're not fitting the standard, so why are you treating us as a standard?
Some of the best cardiologists in my life, some of the best guys. But they do get very focused on getting that cholesterol down, and sort of the only thing that's important to them is the heart rate. And so it is sometimes trying to say yes, but, or to ask the treating neurologist or rheumatologist to intercede and talk with them. But it is, as I say, it's weighing the risk. So the one treatment guideline is based on the LDL, wanting to get that down, but also the HDL, the good cholesterol. These drugs push that up, and that is, each of them are separately risk factors for heart disease. So they do, even with patients with normal LDLs, they'll want to treat the HDL. So is there a way to try to get objective data on this? One of the things I have in our place, there is a biomechanics lab, and I don't use very often, but they can quantitate the muscle strength better than I can do in the clinic trying to push. And I've occasionally sent patients over there to quantitate the muscle base. One guy who was a strapping volunteer fireman, and I couldn't break anything, but he keeps telling me, I can't carry as much weight as I used to. And he wasn't responding to other things. So we could do IVIG, the insurance company involved. So we finally said, well, let's get some data and measure things. So that might be just one thought to say, is it possible to get some more quantitative data than we usually have in the clinic to know if this is actually worsening it? That yes, we recognize that the heart is a risk, but maybe as a compromise, we start with a low dose of the statin, see what happens with cholesterol, see what happens with the muscle, and take it from there. That's what I say. At some point, you've got to balance risks. Having another heart attack would be better. So, okay. I better go get more coffee before I do this.
What's the short answer to what's the pathology of interstitial lung disease and myositis?
Yeah, so interstitial lung disease is basically inflammation. So it's inflammation in the lung, and that inflammation,
The lung tissue itself?
over time, scars. So it moves from inflammation, which is potentially reversible with treatment, steroids, immunosuppressant drugs, to scarring, which is irreversible. So it's wanting to treat it while it's reversible before it moves to the irreversible. And there are subtypes of it. They define usual interstitial pneumonitis, non-specific interstitial pneumonitis, cryptic genital organic fibrosis. They all look a little different under the microscope and on the CT scans, but the short answer is inflammation.